Good morning, everyone. Good afternoon now, everyone. My name is Lauren Sant, and I'm the Executive Director of the Caring Ambassadors Program. And thank you so much for joining the Coalition of State Rheumatology Organizations, Dr. Dave and myself, for sort of a 101 on Prescription Drug Affordability Board and understanding the impacts that they have on patients and providers in Oregon, Washington. It's not just patients, it's really providers, it's the pharmaceutical industry, it's pharmacies, it's the healthcare system. They have an impact on everyone who lives in our states. With that, I will ask Dr. Dave to introduce himself.
Yes, and I'm going to correct you, Lauren, but my last name is Dave. So I'm Amish Dave.
Dave.
I'm a rheumatologist here and practicing in Seattle and Bainbridge Island, and I'm also a board member of the Coalition of State Rheumatology Organizations. I'm immediate past co-chair of the Northwest Rheumatism Symposium, and I'm a board member of the Washington Rheumatology Alliance. I'm excited to see all these people join today.
I apologize, Dr. Dave. And for those of you who do not know who the Caring Ambassadors Program is, we are a nonprofit based in Oregon that has done education and advocacy for people living with chronic disease with a special focus on lung cancer and hepatitis C. And we've been empowering people to be advocates for their health since 1997. So, welcome. I appreciate you all being here today. So, we're going to jump in.
Well, thanks so much, Lauren. We want to talk today a lot about PDABs, which are prescription drug affordability boards. And these are state level boards that are comprised of appointed members that represent different stakeholders in the drug supply chain. Some of these stakeholders could include patients, clinicians, pharmacists, insurers, as well as members of pharmacy benefit manager organizations as well. And the PDABs are really a relatively new institution. They were created in certain states by legislation that was enacted by the governor, and they were tasked with reviewing the affordability of prescription drugs. And I put that word affordability in quotes because we're going to talk a little bit about whether or not drugs are actually affordable to patients or more affordable to the system. And when introduced by the legislatures in the states, the PDABs were really pitched as these opportunities to control drug costs as well as patient out-of-pocket spending on prescription drugs.
So, the PDABs in Oregon and Washington both were established in 2022. And the Oregon PDAB was established by Senate Bill 844. And really, Dr. Dave said it right. It's to judge affordability, but what we don't know is affordable to whom. And that's really the big question. They are supposed to be looking at up to 9 drugs and and at least one insulin product that may create affordability challenges to the healthcare system and high out-of-pocket costs for Oregonians. And at one point, they had to pause because they still had not figured out how to define affordability. So I think that's something as we go through this presentation we need to keep in mind. Washington's mission is to monitor and mitigate unsupported price increases of prescription drugs for Washingtonians. And it's composed of 3 bodies. They're comprised by the governor, and they have a task of identifying drugs that may be subject to an affordability review, conduct an affordability review, and select eligible drugs, and then determine whether that drug is unaffordable for Washington consumers. So the difference between the two boards is that Washington has ability to do upper payment limit and Oregon does not at this point. So we're going to talk about upper payment limits on the next slide. Dr. Dave, you want to talk a little bit about that?
Yeah, absolutely. Thanks, Lauren. So, like Lauren was saying, most of these PDABs, like the ones in Washington, Oregon, are really empowered to recommend drug pricing solutions to the state legislatures and conduct an affordability review of select medications. And the criteria for selected drugs can vary by state. But the PDABs are often considering a number of different factors, including how many years has a drug been on the market, what's the overall cost of the medication to the state. Is there a lot of market competition, or is this drug the only drug approved, say, for a certain condition? And what does price increase look like for a particular medication? When the drugs are selected for affordability reviews by the PDABs, the board is collecting information of the drug from a variety of different places, including manufacturers, health plans, patients, providers, and other stakeholders before determining whether the drug is, quote, affordable. Um, and the affordability reviews are ultimately supposed to be presented to the legislature. Where Lauren is in Oregon, that PDAB is only empowered to conduct the affordability review. But in Washington, our PDAB is also empowered to implement drug price caps or upper payment limits on medications that are deemed unaffordable by the PDAB. And this is a key thing. So the upper price limit, or UPL, is a price ceiling on all purchases, sales, and reimbursement for a drug. The UPL applies typically only to manufacturers, pharmacists, and providers, but it's important to understand it excludes the pharmacy benefit managers as well as the health plans. And we're going to talk more about this because it might put more onus or burden on the providers prescribing these medications or buying and billing these medications. So Washington isn't the only state where the PDAB boards have UPL authority. Other states like Colorado, Maryland, and Minnesota also have the ability to set these upper price limits as well.
And in Oregon, they're currently reviewing 23 drugs and 9 insulin products, trying to get down to that up to 9 or that 9 and that 1. And they just it was 27 drugs. They eliminated 4 because of their orphan designation, but there are 4 migraine products, 3 metastatic breast cancer products, 5 diabetes drugs, 3 for psoriasis, and then you got 1 for COPD, heart failure, MS, schizophrenia, blood thinner, AFib, HIV, and pancreatic disease. So these are a lot of diseases that are going to affect a lot of Oregonians and Washingtonians. Washington is trying to narrow the list down to 10, and they have sort of a weighted way of doing it. We're still trying to figure out exactly how they are going to get this down there and get the information. As far as gathering stakeholder input, they do it through public meetings, and but the problem is they're asking for people to provide very sensitive information and put it on a public website. And so they're not getting a lot of the information from patients that they really need to make decisions about whether a drug is affordable to an individual patient. So I'm sure we're going to talk more about that as we move forward, especially on this slide.
Yeah, great. I love that, Lauren. So, a lot of questions here about what the promises versus the reality of the PDABs are. So let's kind of go through those. So when introduced by the legislature as bills initially, state by state, the PDABs promised to address a handful of issues that were really impacting cost of medications to patients across both Washington and Oregon. And I think our concerns are that PDABs might not be living up to their promises or that there's that there are major concerns. For example, one promise was that from the legislature was that the PDABs would reduce drug costs and make medications more affordable for patients by lowering their out-of-pocket costs.
But the reality is that's really oversimplified. They do not have control of patient prices. Patient does company PBMs and insurance companies significantly impact the access and price of medications, and your insurance design has the greatest impact of your out-of-pocket costs. It's not the list price; it's your insurance package. So that's the reality there.
A second promise, made by the PDABs was that the PDABs would fix the high cost of prescription drugs by limiting the price of medications.
And this is really problematic on several levels because it if they make an upper payment limit, that doesn't mean that that's what someone's going to pay. That just means all they're going to get reimbursed. So our pharmacies are going to go underwater big time if this goes through because they may or may not be able to purchase that drug at the same price, especially if they're in multi-state pharmacy contracts. They may never be able to get that drug at that price, including providers might not be able to get that drug at that price. And so it's not reality. And the other part of that is the Partnership for Fight Chronic Disease did a phenomenal report with Avalier, and 77% of health plans surveyed said that UPLs would disrupt patient access to prescription drugs. It would change the coverage, it would change the tiering, it would change cost sharing, and and it would broaden the supply chain issues, including pharmacies that I just talked about. 67% of health plans anticipate the cost sharing for UPL drugs will increase 50% or for most people. Um, 70% out-of-pocket costs for drugs will increase. Um, Again, they are going to increase utilization management. 50% said they would increase utilization management, which means prior authorizations, making you jump through hoops. Dr. Dave can talk about what that looks like for patients. Um, and that 60% of respondents believe that pharmacies wouldn't be able to stock the drugs of upper payment limits because they were going to have critical shortages. They would not get reimbursed. They would not have a guarantee that they would get reimbursed for the same price that they paid for a drug. So that's really the problem with that simple statement, we're going to fix the high cost of prescription drugs.
I think Lauren has brought up so many like key problems or concerns about the second promise. And then, I just bring up the third promise was that really that the PDABs would encourage consumer participation in this whole process, but also that there would be an opportunity for prescribers, physicians, nurse practitioners, physician assistants to really get involved in the process too, and hopefully advocate for their patients to lower the cost of drugs.
But in reality, there's 10 minutes once a month well, once every other month in Washington, but once a month for 1 to 3 minutes of verbal testimony. And don't forget to sign up early. We'll talk about that later. In the middle of a 3 hour meeting in the middle of the work week. And so not many providers are able to just drop everything they have and attend those meetings. And then if they want to provide something in writing, again, it's public record. So there is no one-on-one, there's no true engagement of working with patients, of working with providers, getting expertise, and really finding out where those barriers are. So again, no meaningful public engagement from these people.
So I think, Lauren and I bring up some of our concerns about the PDABs, and that's really why the Caring Ambassadors and the Coalition of State Rheumatology Organizations are here today. We're really concerned that the PDABs might be falling short of their promised results. And we're also really concerned about that the PDABs themselves might end up becoming a real threat to healthcare providers and our ability to care for our patients. To start with, these payment limits or UPLs are really structured so that they're capping prescriber reimbursement for any drug selected for a UPL by the PDAB. So, in other words, the law does not require that providers acquire the medication at a rate that's sufficiently below the UPL to account for acquisition costs to the provider, which means that providers cannot receive the add-on payment that they might be expecting that oftentimes helps their medical practices to financially account for acquisition costs. What does that mean? Well, when you're prescribing a medicine or ordering a medicine and storing it, acquisition costs could be anything from the expenses required to cover intake and storage, the equipment and the preparation, the nurse staff or infusion nurse staff, facilities, and spoilage insurance. None of those are really accounted for in the UPL. If your healthcare provider does not receive even a small payment to cover those aspects of drug administration, acquisition, and storage, it makes it almost impossible for them to continue to utilize that drug in their office without suffering significant losses, especially over time, and if that medication is very commonly used. So this is a huge problem for healthcare providers, especially those who are directly administering an injection or infusion to their practice. And we're not just worried, even though I'm a rheumatologist, I'm not just worried about my rheumatology patients, but also worry about my colleagues in oncology, ophthalmology, gastroenterology, who might be using some of these high-cost specialty drugs for their patients, especially patients with rare conditions who might have already tried multiple medications and have a really hard time getting the medication that works best for them. We're also really concerned that the medical practices won't be able to purchase drugs with the UPL at the capped rates. So medical practices work, for those of you guys who are in private practices, who are not in a large system like myself, you know better than I do that medical practices are working with a whole range of folks in the pharmaceutical chain, supply chain to get the drugs that we administer to patients, including group purchasing organizations, wholesalers, and manufacturers. It's really it's highly likely that a wholesaler used by a medical practice is often operating outside of, say, Washington State or Oregon, or any other states like Minnesota or Colorado with an upper payment limit, which means that the price offered by the wholesaler to the medical practice would be significantly different, probably much higher than the UPL that a state has imposed, which means that it might just become really hard for medical practices to purchase those drugs that have been selected by the PDAB to be at a UPL rate, which could lead to medication access shortages and limited patient access to the medications they need. And that is a huge concern. Um, and finally, one more thing I want to say before turning over to Lauren, which is, there's no guardrails in the law that ensure that health plans will cover the medications with a UPL on a preferred tier. So even if a state tries to limit the costs of these prescription drugs through the upper payment limit, the health insurance plan could choose to, or the PDA, or I'm sorry, the pharmacy benefit manager could choose to place that drug on a fourth tier, making it even harder for patients to access that medication. So patients, we know already have to often undergo extensive step therapy to get on a medication that works to control their disease process, like their inflammation and rheumatology cases. They might even need to undergo even more extensive step therapy before they could access a drug placed on a fourth tier, which means that there might be delays in care, more harm to the patient, and oftentimes an extraordinary amount of administrative burden for healthcare providers as they try to secure that drug for the patient, which is a huge problem already because I can tell you in my practice already, even though we have dedicated pharmacists and amazing staff that's trying to do prior authorizations, they're already under a significant burden. And so adding to that burden through these processes of the UPLs might just make the whole system that much more fragile. Oh, I'm sorry, Lauren, I don't know if you want to add anything to what I just said on that last
I
slide.
think you got it covered.
Okay. Well, and so I want to move on to this concept of like patient-centered care and where the PDABs are. So obviously the promise of the PDABs is that they'll reduce the cost to patients and to the healthcare system as a whole. But I really just want to focus on the fact that the PDABs as they've been structured so far, state by state, are really focused on this idea of cost to the system and not necessarily focused on any one individual patient and patient-centered care. That's really the focus of us physicians, though, right? As a physician, and by my Hippocratic oath, my goal is to make sure that my patients have less harm and less risk of death. My priority is to make sure that my patients get the right medications or right treatments to best help their rheumatological conditions. Um, the boards, though, the PDABs have really been set up, though, to value economic data and for, quote, the system as a whole over clinical outcomes and medical guidelines that could really help a patient's outcome. So, for example, when evaluating drugs for their affordability reviews, for example, these 10 drugs that will be selected by the Washington State PDAB, the PDAB is really it's supposed to be considering whether drug has any therapeutic alternatives, but not all therapeutic alternatives are actually therapeutically equivalent. So patients might not respond to one TNF inhibitor and they do to another. And trying to switch a patient or making it too expensive to get their medication that's working for them can have drastically adverse outcomes for patients. So deeming medications, quote, therapeutic alternatives as a one size fits all approach might also further disrupt the physician's ability to select a medication that's best for their patient. We know in rheumatology, as in other fields like oncology and GI, that our patients are often spending months or years of trial and error before they find the right medication that's controlling their disease, if they ever do. And so we're trying to really, hopefully, try to reduce that period of time to which they get on the right medication that works for them. And once we find a treatment that works, we really are thinking about every individual patient as an individual with unique medical histories and side effects that they might have experienced with other drugs when we're thinking about, or side effects they're experiencing with their current medication, as well as their labs when we're thinking about whether to continue that patient on a particular medication or not. That's not true of broad decisions by a PDAB. And I really want to emphasize that slight deviations in treatment or variations between drugs can have huge impacts on patient health and outcomes. And that's why when healthcare clinicians or providers evaluate medication substitutions, they're typically considering therapeutic equivalents and not just alternatives like the PDEBs are doing. So we are really concerned that if a board, not your doctor, is able to dictate en masse which medications you can get, it can really exacerbate non-medical switching that can harm patient outcomes. And it's already kind of a challenge for our practice at the beginning of the year in January when we're suddenly having to redo PAs at the beginning of the year for almost all of our patients. Imagine how much more complicated it'll be if medications are switching, um, if different medications are showing up for UPL based on what a PDAP thinks in our states.
And another big concern about PDABs is same thing, quality-based assessment of the drugs. And so for those of you who are not immersed in qualies, which most aren't, quality life adjusted years or quality, it's a metric that's used to determine the value of health to a healthcare treatment. But to calculate that, they assign a value to a person's life. And seniors, chronically ill people, people with disabilities, all have a lower value than a young, healthy person. And so we're starting with automatically that you're healthy, you're perfect, you get the whole enchilada. But you have peanut allergy and all of a sudden you're zero point 0.8 of a person. You get blindness, you're zero point 0.6 of a person. You get MS, you're zero point 0.5. Lung cancer, you're zero point 0.5. All of a sudden the value of your treatment goes down in people's eyes, although to you as an individual, there is no exception to the value for you. And so in Oregon, we have been able to have QALYs banned in the use of their healthcare decisions because they used QALYs for quite a long time. And that has been banned now. But there's still a potential for the PDABs to use what they call sort of quality light or another version of quality. And so we're very concerned because it's not one size fits all, as Dr. Dave said. It really ignores the nuance of patients. Patients are not less than one versus the other. We can't pit people against each other, diseases against each other. Everyone is valuable in our world. And restrict approaches are just going to put treatments out of reach for people. Absolutely. Value assessment is unlikely to account for clinical knowledge on patient variation that isn't in the research already. So your doctor knows so much more than what's going to be on the FDA label. And so really looking at all of that is so important. And so, well, the qualities are banned in Oregon. They're not banned in Washington, to my knowledge. And so that could come into play, and automatically your life is less than than a healthy young person. So it's really unacceptable that they're going to base drugs based on whether you are a full person or not. So
So, agree with all of that with Lauren, and we'll see how much qualities play a role in Washington State with with our PDAB. This is a slide that I think means the most to me, and so I want to say a number of things about it because when I'm thinking about medications, I can prescribe many different medications in my clinic, but if it's too expensive for a patient to pick up, I know that there's going to be an adherence issue, and I have to have these discussions every single day with my patients, particularly patients who might already be struggling with disability, challenging or poor insurance coverage, or through unstable job situations or insurances that keep switching through their employer. And I think the PDEBs really, state by state, the real hope was that they would lead to reduced costs for patients. But instead, the PDEBs are really focused, quote, on affordability of prescription drugs. And I think in some ways, they've really lost sight of what the real costs of these medications are to our patients. And I really want to emphasize that, having a board and not your doctor decide which medications should be available to the patient because of cost considerations, really has an impact on interfering with the doctor-patient relationships. When a patient's coming to see me in clinic, it might be because they have such swollen hands that they can't work. It might be because their lupus is affecting their breathing. It might be because they're having severe telangiectasias and bleeding from their gut with scleroderma bowel. And when we're talking about how their symptoms are impacting them and what we can do to get them on the right medication to control their disease as quickly as possible with as little morbidity as possible as well. And patients might be, experiencing complications sometimes from these medications as well, including from our biologic medicines. So we're often talking about everything from uncontrollable itching or redness to injection site reactions and trying to find the medications that's going to work best to treat their conditions with as little side effect as possible. When a patient or if a patient can't suddenly access their drug that it's taken them a long time to be on because of access restrictions that were unintentionally caused by UPL, then the patient's disease could continue to progress. And this obviously is going to create a huge impact on the patient, a lot of source of frustration, and damages the physician-patient relationship because the patient might not understand that a medication is just too costly for a particular practice or hospital to be able to store or even to acquire. And they don't understand that. And that's going to be a huge problem. And we know in rheumatology that disease progression, when you're having inflammation and sequela to the organs, it can be irreversible. It can be life-threatening. And it really can you can really have a patient go from being highly functioning, enjoying their life, enjoying their job, to really not being able to do those things. And that's a huge, huge issue. So I'm also really concerned that the boards are really looking at drugs that are, quote, unaffordable, but also with diseases that are very rare, and um, and diseases that are very complex and that can have really bad outcomes if patients aren't on the medications that can control their disease. And I worry about cancer patients and what might happen if they can't get on the right medication or if there's a delay in being able to access a medication and what that might mean with a patient being stage 1 and stage 4 due to a delay in medication access. And I worry that some of our sickest patients that we're seeing, including patients with severe vasculitis, lupus, rheumatoid arthritis, looking at state by state what's on the list of medications that's on the PDAB list for a UPL. I worry that some of the sickest patients are, in a sense, part of this PDAB experiment, and that their lives might be forever impacted and changed. And so, as Lauren also mentioned, there's nothing in the PDAB that requires the upper payment limit, the UPL, to reduce the out-of-pocket costs for patients. So one way of looking at this, and this is an analogy that I like, is the government might reduce the price that the dairy farmer can sell their milk for. But just because the farmer can only sell his gallon of milk for $1 doesn't mean that Safeway isn't going to sell it for $4.50 and pocket the difference. So in this situation, you might think about the drug manufacturer as the dairy farmer and your health insurance company and their pharmacy benefit manager as the grocery store. And what happens if the dairy farmer is just not making enough money and stops producing the drug or producing the milk and decides that, they're just going to sell it overseas or to another place? These are real issues, and these are things that we need to be thinking about. So for patients, you might still pay the $35 copay and still reach your $5,000 deductible for your expensive medicines and see no benefit from the UPLs, despite, quote, the state or healthcare plans making a savings. And there's nothing that requires your healthcare plan to reduce how much that you're going to pay or patients are going to pay for their drugs, um, in states with a UPL.
So we really need patient participation. So you've heard some of the barriers that we've talked about here, and a lot of this, if we could have true voices speaking up at every meeting and letting legislators know what they feel about the PDABs, not just the PDAB, but letting also reaching out to legislators and talking to them, because it's so important that the patient voice is a part of this process. We need the boards to be informed about what makes your drug unaffordable. Is it because you're on 5 drugs? Is it because you have to take off work to go get this drug at the hospital, and so then you lose work and you have to have transportation? Is it because your insurance company put it on a tier four? What makes that drug unaffordable? There's so many variations, and without that information from patients, they cannot make a decision on how affordable. And again, I'm going to bring it up: affordable to whom? The healthcare system or truly Oregonians and Washingtonians? So, and this goes for all PDABs. I don't mean to, I mean, Maryland, everybody else, Coloradans, it's all PDABs. And they're rushing the process. So in Oregon, I was very proud when they stopped the process and said, okay, well, we need to go back and really define how we define affordability, and yet they started the process again without doing that hard work. And so it's again a rushed process. They put out a survey for patients on April 1st and wanted all the data by April 30th. That's just not reality in this world. Most adults have not even written a letter in the last 5 years, much less written a public comment in a public space about their very personal health condition. And so we really need to advocate for transparency, engagement. We need patient advocacy boards that are part of the PDABs so that they're really listening to patients. We don't want just one patient on a board because who knows what that one patient's experience is going to be, but a group of patients from a variety of diseases to help direct these PDABs. Unfortunately, they are not interested in that at this point in time in Oregon. But that would be our druthers, is to have a board that where we can really discuss this and discuss the nuances of what's affordable. So, in the meantime, make your voice heard, show up, write, do all the things that they're asking to do. And we're going to talk a little bit about that, the next steps on that, and just the next slide. But I do want you to like don't shy away. Please speak up. Providers, patients, everybody needs to speak up. So that's my message there is be loud. The squeaky wheel does get the grease. So even that loose panel in the back of your van, you are going to fix it. So like let's fix that loose panel in the back of the van in Oregon. Um, so
So I think Lauren did a really good job talking. Oops,
go
I
ahead.
think
Go ahead.
I I think one slide back, Lauren. Yep.
Got
So
it.
I think
Yep.
Lauren did an awesome job explaining how to for patients get involved in the PDAP process. But I think for all the same reasons that she's just said, it's also so important that our clinicians get involved in the PDAP process. And whether you're a physician assistant, whether you're a nurse practitioner or a nurse, everyone on the patient care team should really get involved for a lot of those same reasons. In Oregon, the board is actually also looking for a healthcare provider to fill an open slot on the board. And I just want to emphasize, if you're interested in that, please reach out to info@csro.info for further information. We're happy to provide it to you on how to get involved with that board. If Oregon ultimately adopts a UPL, I think this position will really help to decide what a UPL ends up being, and therefore what physician reimbursement is limited to, and what barriers might occur for physician reimbursement. So that's really an important role. I'd also just say that, that the process of joining the PDAB seems to vary state by state, but there are a lot of restrictions for physicians, including if they have any funding at all from any sort of pharmaceutical industry, which really often limits the ability of a lot of private practice rheumatologists and neurologists and oncologists and other specialists to serve on these boards. Um, Interestingly enough, a lot of those same limitations are not always true for other members of the state level PDAB. And a lot of the PDAB members end up being former members of the state legislature who might have taken donations over many years from many different individuals or entities, as well as heads of pharmacies. So it's interesting that those individuals might not be limited by their involvement in the pharmaceutical industry or other donations from PBMs, et cetera. But the physicians, definitely, there seem to be a lot of limitations.
Yeah, including we've had some PBMs on these boards. So there's definitely a lot of conflict of interest that exists that that they seem to not they just seem to key in on providers and patient advocates. Quite frankly, they have the same feeling about us. So it's unfortunate, but please apply if you are interested. There's also in Washington State, there is an unpaid volunteer for an advisory group member. And the advisory group serves at the direction of the board and provides guidance to the board. And so another way that if you're interested, you might be able to get in to that. So in Oregon, it's you can submit public comment, but you have to do it 24 hours before the meeting, and you'll have 3 minutes. They say there's 10-minute slots, so however many people show up, you usually get 1 to 3 minutes. Um, you have to register online and register to speak, so don't you have to do both. And the link there for the upcoming meeting is coming up. There is one tomorrow. So unfortunately, it's too late. If you would like to add public comment, it's too late to talk because you have to do it 24 hours before. But there's another one coming up in July. Written comment is 48 hours before and has to be sent into them. And anything sent after that will be sent for the next month's board meeting. And they are very strict about this. So, and again, you have to register to even attend the meeting in Oregon. Dr. Dave, you're muted.
Thanks so much. Such a rookie mistake so many years after the pandemic. But and similar to Oregon, we welcome people getting more involved in providing comments in Washington State. So you can email the Washington Healthcare Authority, PDAB, by the Monday before the meeting dates that are listed online with your name, organization, and topic on the agenda. And you'll get about 3 minutes to speak. If you don't sign up ahead, then you can raise your hand when the chair asks if there's other stakeholders to wish to speak. And we welcome people to check out the website below on the screen to find out more information about board meeting dates and the link to register. I'll also just say that as Washington State pursues its upper payment limit, they have released a preliminary affordability review shortlist, and it includes a lot of non-specialty drugs like pills and tablets, as well as specialty drugs like biologic injections. And these are medications that treat a whole array of different conditions, including hepatitis C, rheumatoid arthritis, multiple sclerosis, and cancer. And so, a lot of our patients potentially impacted. And so it's important for folks to engage with the Washington board. And if you can participate during the meetings, it's helpful to learn a little bit more about how to advocate for your patients and potentially more cost savings for patients, as well as making sure that hospitals and clinics providing these medications can stay solvent. And even if you can't step away from a busy clinic day, which is usually my case, you can still send out a letter outlining your concerns. And then one final thing I'll say is that, we're very blessed in Washington State to have a really great Washington State Medical Association. So with a team of lobbyists. So definitely feel free to reach out to them or to our Washington Rheumatology Alliance membership because we want to hear from you. And we're always happy to help direct you to where you need to get your comments and concerns sent.
So we have a couple of questions in the chat already that I want to start with before we open it up to folks. But Dr. Ettlinger, I'm sorry if you're not a doctor, but Robert Ettlinger asked, do PDABs interact with the state health insurance commissioner's office at all? Well, in Oregon, it is actually run in the same office out of the Department of Business Consumers. So yes, they are very interactive and are
And my understanding in Washington State is that there is discussion with them. I do not believe, and maybe Jessica can correct me if I'm wrong or someone else can correct me, but I don't think there's, quote, a formal role for them in this. And I think there's a strong feeling in the Washington PDAB that they want to reduce as much bias as they can.
And Robert also asked about qualifications considered for PDAB members and how we can influence the candidates and how long does their appointment last. One thing I'll say about influencing candidates, they open up the Oregon meeting and ask if anybody has been approached by a lobbyist or anyone else every meeting. So it's hard to influence them other than just keep writing letters. And there are several members of the Oregon board that are very good at reading the letters and reiterating the concerns in those letters in the meeting for those that might not have read all the testimony. So I think there's some strong board members that do that, and if you watch the meeting, it becomes quite obvious very quickly who's actually reading that testimony that's coming in and who's not. So qualifications, I know the Oregon opening, they really want a doctor in this case to get the panel back to balance. I don't know, Dr. Dave, about Washington.
My understanding, I mean, last year it was an open position, and my understanding is it was filled. I do not know who that individual is, but I also know that the process of filling that spot, it was very challenging because, as you can imagine, a lot of the physicians who I think are most engaged in these advocacy topics also have some experience in private practice. They might be buying or billing with different pharmaceutical manufacturers. It's really hard to quote not have a conflict of interest if you're an independent practitioner. And they really limited that ability. You'd have to essentially be an academic who is separated from the buy and bill chain, and thereby is missing maybe some information about what that means to private clinics or independent practices or hospitals to be able to serve on the Washington State Board.
Do you know the time limit for serving, or how long the sentence I was going to say, how long is served?
Yeah, I do not know specifically for how long the appointment is for.
Um, I believe it's 2 years in Oregon because they started in all three, maybe 3 years or 4 years because they started in 2022 and they just reinstated everyone. Well, not everyone, quite a few people. So I'm gonna guess 3 years, maybe four by calendar. But maybe someone else on the call knows the answer to that. It's a great question. If anybody wants to raise their hand if they know it or throw it in the chat, that would be wonderful. Um, and John Covello also put a link in the chat if you didn't see it. The risk to patient safety and access to these drugs from the Partnership for Safe Medicines and the risk for, needing pharmacies to make sure we have a drug system. So yeah, great link there. And Washington does explicitly invite international data and prices collection, which is quality-based data. So thanks, Sarah, for that input. All right, and got another one in there. Any other questions? Somebody want to raise their hand and I can unmute you. Ronnie, hang on, let me find you on here. Maybe. Oh, gotcha, Ronnie, go ahead.
So state of Washington, I'm Ronnie Shore, and I'm a retired pharmacist and a healthcare advocate, knowing that since I retired, been focusing on the fact that our healthcare system is just so non-transparent. The issues that you're talking about certainly can be exacerbated by PDABs, but boy, they're built into the system. I mean, just talking about qualities. Is that how drug manufacturers create their price in the first place? I mean, where is this whole thing starting? But my role is I volunteer to watch the meetings, and it's one of the advisory groups. Uh, the board members, there is still a vacancy in the PDAB in Washington State. I think I know they would love to have a clinician who's available. Uh, there are three pharmacy people, professionals involved, and one is from Multicare, from a private institution. So that doesn't exclude someone. There certainly can be conflicts of interest anywhere, but it's 4 years appointment by the governor for this particular board. There is a vacancy, and boy, these are really important issues. Provider voices, patient voices are so needed to overcome the confusion. you spoke about pharmacy benefit managers, but a private doctor's office is stuck not just with that, but with the laboratory and the supplies and other third parties that just make our whole system hard for the provider as well as hard for the patient. So my reason for being involved, just the bottom line, is that I think we need more transparency and that PDABs can be working on those issues. I don't think there will be a magic upper payment level that everyone is going to abide by. We have too complicated of a system, too many ways to get around that. So I think that PDABs, the role we should look for or the value we can get out of these PDABs is to make the system a little more transparent. It's not going to be an easy battle. And it's well entrenched. I mean, it's our whole society is based on that, our whole healthcare system is based on that private or profit motive. We just have to balance that. What is too much profit? What can we do? And PDABs can look at, opening up or at overcoming some of the transparency or lack of transparency problems. And I think the goal or the goalpost we should put for PDABs is comparing drug prices with inflation in other areas. There's no reason for us to be paying more for drugs than we do for the milk or the eggs that we were talking about. We need to balance that out. There's got to be someone saying that's enough.
So you're correct, and one of the issues is they don't have the authority to do that, and so they don't have the authority to look at the whole chain. Um, and if you're only given a hammer as your tool, that's all you're going to use, and that's what they're using as a hammer on the drug price. And yet, you're right, we need to look at the entire infrastructure and the whole system and where we can put pressure to make changes. I know the Oregon PDAB has recommended several to the legislature several options to UPL that they suggest will lower the drug prices for Oregonians, but those haven't been taken up by our legislators. And so, well, a few of them have, but mostly they've been ignored. And so, you're right, Dr. Dave. I can see you have something to say there.
Yeah, I would say one, Ronnie, I was just going to say thanks so much for listening in on those and serving on the advisory board. I think that's such a awesome thing to do. And I think it's important that people continue to follow up what's going on in the PDEPs. I would say a few things. One is, that's great to know that there's that open position. Um, I had applied for this or thought about applying at some point in time. Apparently, from giving one talk for a pharmaceutical company, I was told that I should not apply or that I would be excluded from doing so. So I certainly welcome the opportunity for another physician to potentially join the PDAB board in Washington State and provide information. But I would also say a few things. One is that multi-care, as was heavily reported in the media right after the pandemic, is one of the wealthiest healthcare organizations in the country with some of the largest reserves, which allowed them to basically buy Tacoma General Hospital. And I would also point out that, it's great to have the input of a large hospital system, but I think what we're missing is smaller practices and independent practices, which about a quarter to a third have shut down in Washington State since the pandemic. What we're also seeing in Washington State is a lot of these large hospital systems are basically unburdening themselves of infusion services. So we're seeing a proliferation of infusion centers opening up across Western and Eastern Washington as the hospitals themselves have decided that it's not profitable for them to give infusions to their patients. And that's a huge problem, right? And that goes back to this whole issue of buy and bill no longer being affordable. And that's not considered by the PDAB when they set this UPL. So what's the cost again of storage, administration, acquisition, and having staff who can give these medications to the patients? So patients are paying more, at least what I've seen. My patients across Western Washington are paying more from driving back and forth often 50, 60, 100 miles to get their medications because their hospitals are no longer able, or clinics are no longer able to provide certain medications. Hospitals are no longer actually being able to afford some of the biosimilars or prescription or brand name medications that a patient might benefit from. And so all of these are big considerations. I hope that a physician is able to join the Washington PDAB to bring about all these concerns, but I still think that we're concerned that that large portions of the, as you said, complex healthcare jigsaw are just not being addressed right now by the PDAB as they focus just on one aspect of the healthcare cost.
Other questions, comments, thoughts?
And we're seeing a little bit of different numbers, but Susanna Waldman noted it's 5-year terms and not 4-year terms. So we can clarify that at CSRO about the Washington State information if anyone's interested, and certainly provide that information to folks. Thank you, Susanna.
Okay, great. Gone on any other go? Wait, John. Let me unmute you. You should be able to unmute yourself now.
Yes, I can. Thank you very much for this opportunity. And I represent a group of independent pharmacy owners in both Oregon and Washington State. There are other people from the pharmacy industry on this call as well. I mean, you've done a great service to showing how big a problem this is of not knowing what they don't know about how the drug supply chain works. And we've made comments to Oregon a number of times in their meetings over the years. One thing that I think people don't truly appreciate, and Dr. Davi, you touched on it, is central at the role of all of this are the PBMs. They ultimately decide plan benefit design, cost sharing, and ultimately the encounter cost of these drugs back to who's ever paying the bill. And, this touches a lot of different areas that I think the boards need to look at. What about 340B covered drugs from B340B covered entities with their covered patients? The Medicaid programs in both states, are different and need to be addressed on this. Certainly, there has been movement around the country in commercial marketplace to address some of this. The real problem, I think, is for those cash customers that have no coverage, can't afford the Affordable Care Act, even with the subsidy. What happens to them? But Dr. Davi hit it on the head. The upper limit, it's almost like what we're going through with the Medicare negotiated drug prices. There, the manufacturers are required by federal law to make pharmacies whole at the end of the day of the price difference. There's no way a state can do that with these. What we've raised as an issue, and it's now actually doubled the number of states doing this. And unfortunately, Washington State doesn't apply it to all their payers, is to really go to a transparent cost-based pass-through. What it costs pharmacies to purchase these drugs at, plus their fees, and pass that through without the PBMs getting anything more than administrative costs. That's what helps determine what are the true plan costs, because it's something more predictable. We'll see in some of the states doing this what it really does to these specialty drugs. Also, the advantages of each of your states is a little different. Oregon has designated that you can't have the PBMs designated a drug a specialty drug, while Washington state law does not. And you do have anti-mandatory mail order protections in Washington state, but I don't, and in Oregon state. And the other thing that has to be addressed that both states have, I think, that to be looked at is prohibitions against copay accumulator bans. Where does that go in terms of helping meet the affordability to the patient while allowing the economics of the drug supply chain to exist the way they exist? And I know it was raised in Oregon State. I don't know about Washington State, but both states have an all claims payer database with proper guardrails and confidentiality protections to get to aggregate data. That should be used as a resource to make sure that they really have everything that is necessary there to understand what's being paid for these drugs. And finally, the only other caution I have is the PBMs can easily find a way around these PDABs in ways no one else can. As you may have heard, they're now vertically integrated with other companies. Some of them own offshore group purchasing organizations. They can certainly, with their purchasing power, force manufacturers to pay them below that prescription drug affordability benchmark price. Basically, steer all those drugs to themselves and make a profit and harm really patient access and pharmacy access, where no matter what the laws say about anti-mandatory mail order, like you were saying about the tiers, that's going to be the only place you can find them. And it's kind of totally undoing any of the benefits people think these PDABs are going to do to contain costs. So, and we still don't know one last thing, whatever the Trump administration is going to do on international reference-based pricing could be a whole game changer that makes all of this irrelevant. So I know I've said a lot, but hopefully the input from the pharmacy side is important. And thank you for having this. And I look forward to any future dialogue.
Thanks so much, John. I think you brought up like so many key concerns that we were hoping to highlight in this question and answer. If you ever want to join our CSRO, I think we would totally welcome you as an ally or an advocate because you bring up a lot of the concerns we have, especially with regard to copay accumulators and increased costs for patients, as well as the real challenge of the PBMs, three of which are three of the 10 largest companies in the United States and have really zoomed in terms of their profits and their mammoth power.
Yeah, and in Oregon, we did get copay accumulators banned for private insurance, but it doesn't cover the public employees. And so, it's kind of like, well, and then that one did not pass. And so, yeah, it's crazy. And mail order is banned, mandatory mail order is banned in Oregon. However, the PBMs get to decide what a specialty drug is. They get to define it, and then they can make it be mail order, which is what they do with hepatitis C drugs, for example. And so it's completely unacceptable. PBM should not be able to define what a specialty drug is, in my opinion. But
yeah,
that's where we're at. So, but we do need the pharmacists. We need to all work together because you are such a critical part of the consumer chain, and without you, we're really in trouble. And without you everywhere and in all of our towns, we need you. We don't want, PBM pharmacies dictating the world. So
thank
you. Anyone else? Or 1 minute to the hour. I want to say thank you to Dr. Dave and just everyone on this call for all your attention, and let's make it happen. Let's communicate with these PDABs. Let's make them change to be the body that they should be or could be, and really address affordability for people in Washington and Oregon. So thank you. Any last words, Dr. Dave?
Well, I was just going to thank you too, Lauren, for being such an advocate for patients, and just say that we welcome emails, requests for further information or further questions that people might have as they're musing on these thoughts on hopefully a beautiful day in the Pacific Northwest. Please reach out to us. We obviously get involved in this because we love advocating for patients.
And I put my email address in the chat for those folks that don't have it, Lauren at Caring Ambassadors Program or caringambassadors.org. And I think we had the CSRO email in there a bunch. So please feel free to reach out. Anything we could do. We will have this presentation to share, so you can share it with your colleagues. If they weren't able to join, we will make it available. So thank you again for everyone coming today. Have a great day.